All right, so clearly decompensated cirrhosis. These are patients that we don't, want to treat. Usually when they're decompensated, it's fairly easy to recognize. This is not going to be subtle. If someone has a large belly, they're distended, especially when the abdomen is large and they have muscle wasting. We have a lot of people in Southeast Louisiana that may have a large abdomen, but especially when you see that muscle wasting in the arms and the legs. But so the belly is the only thing that seems protuberant. You have to think that could be associated with more advanced liver disease in someone with hepatitis C. Certainly, ascites is one indication of decompensation, like you see in the top left, the fluid in the abdomen. You also see jaundice depicted in the top left picture and also in the bottom right picture. It's important to remember that people with more melanin or African American or have darker complexion, then jaundice doesn't look the same. So it's not as easy to pick up someone who's yellow, that's yellow, when their skin already has a pigmentation to it. But the thing that doesn't lie are the eyes. So there are patients that come to me and they think they're jaundiced, but if their eyes are white, then they can't be jaundiced because it starts really in the eyes. So you notice the eyes being yellow before anything else. And most individuals, whether they're of African descent or not, or African American, you can still tell in the sclera if there looks like there's some jaundice there. Then of course, if someone has variceal bleeding now, you won't see that probably when you're talking to them, but if there's any history of variceal bleeding, then that's obviously, a concern. The brain picture is if someone has delays in their thinking, not thinking clearly. I always tell patients it's not just like when you go into a room and you're not sure what you went in there for. It's when you really have like a brain fog, like your thinking is just slowed. So someone, let's say, for example, was an accountant and so they can do numbers easily, but now they're having trouble with just some basic math things. That doesn't mean they're completely confused, but they're clearly not thinking like they should normally as someone, of their level. And so if any signs of hepatic encephalopathy is consistent with decompensation, and then we talked about again, this shows kind of some jaundice in the hand, or sometimes we say palmar erythema. But the problem is that patients can be decompensated even when these symptoms are not present. And so we need to be mindful of that. So a clinical decompensation is different than a lab kind of decompensation. So that's what we'll talk about on the next slide. And so if someone has cirrhosis and you're not sure if they're like decompensated, then you may have to calculate a child's Pew score. Now, again, this is not going to be a common thing. This is unlikely that you'll have to do this, but I just want to mention it because we want to just arm you with all the tools that you need to feel comfortable taking care of patients who have hepatitis C and who have liver disease. So let's say they don't obviously have encephalopathy, don't have jaundice, they don't have ascites, they don't have variceal bleeding or any of those things, but you look at their labs and you're like, well, the bilirubin is a little bit high, the albumin is a little bit low, then you may be kind of confused about if that person has more advanced liver disease that perhaps you shouldn't be treating. And if that just comes to your mind, then I suggest checking a child's Pew score. Again, if it doesn't come to your mind because the person looks normal, on exam, there's nothing really remarkable. Their labs are pretty unremarkable. Then you don't have to calculate a child's Pew score. This is just in case something seems off to you and you're not sure, then there are a lot of online calculators like MD Calc, University of Washington has a great set of calculators. And you put in, okay, a score for encephalopathy, for ascites, for bilirubin, for albumin, and for the prothrombin time or the INR, then that will give you a score. So if they're Child's Pew A, which is class A, they have 5 to 6 points, then we consider that to be compensated. Okay, but if they're Child's Pew B or C, we consider that decompensated. Now, again, they're not clinically decompensated, but there's enough suggestion there that they have enough dysfunction in their liver disease that those are a population of patients we don't want you treating in more primary care settings. Those individuals would need to be referred, to a specialist. And it's interesting, it doesn't take that much to get to 7 points actually. So you have a bilirubin that's kind of at 2, and then you have an albumin, that's low, then that will kind of get you there. So just be mindful of that and know that you have these kind of resources at your disposal. Any questions on the Child's Pew or decompensation kind of classifications? No? Okay. The next slide. Another scoring system that we talked about before is called the MELD score. So the model for end-stage liver disease score. So the MELD is what we use in the transplant world to determine when someone should be referred for transplant evaluation. Interestingly enough, just like I said with the Child's Pugh score, you'd be surprised. There are patients who appear to be compensated, right? They don't have any of those clinical signs and symptoms of decompensation, but their MELD score actually is high. And what's high? Anything greater than or equal to 15. So again, these are the characteristics that go into the MEL score: age, sex, creatinine, bilirubin, INR, sodium, and albumin. So some of them overlap with the Child's Pugh score, but not all of them. So we use both the Child's Pugh as well as the MELD score as prognostic scoring systems or indicators in patients who have underlying cirrhosis. So you do not check the scoring system when someone is not cirrhotic, but if they are cirrhotic and you're wondering, hey, is this a cirrhosis that I can manage, that I can treat in my clinic? Then you want to make sure you feel comfortable that they're compensated. And so the Child's Pugh and the MEL score are a way for you to kind of confirm, if you need to, that you can treat these individuals in a more of a primary care setting and that they don't have to be referred. So if the MEL score is greater than or equal to 15, even if the person looks normal and have no clinical signs of decompensation, that's someone who you should not treat, and you want to refer them usually to actually for transplant evaluation. And so not just to a gastroenterologist, that person probably needs to be referred to a hepatologist. Any questions on the MELD score? All right, if not, next slide. So you want to look at all these things in total. So we talked about symptoms, we talked about Child's Pugh, we talked about MEL score. So the three assessments may not agree, right? So one may be telling you someone is decompensated or higher risk, for poor outcomes or should be referred, and another one, may not tell you that. Like we said, from symptoms, they may not have any, but you want to look at all three. And if any one of them is concerning. So if they have symptoms or a Child's Pugh that's B or C or a MELD score that's greater than, and really it should say equal to 15, then you don't want to treat that individual. You want to refer them to a specialist. And I would suggest that, like I said before, not just a gastroenterologist, but at this point, you probably need them to be seeing a hepatologist. If you're unsure, that's why we have Project Echo. You can always kind of bring cases here. And it's supposed to be a two-way street, didactic as well as case based learning. So we're happy to discuss those cases here in terms of what you should do, and or you can obviously call a specialist. I'm always happy to consult on different cases if you have a question, even outside of the Project Echo session, and we can discuss together whether or not that's someone that can safely be treated in more of a primary care type setting versus being seen by a specialist. Next slide. So who do you want to refer to as a specialist, or not even just a specialist? Maybe it could be a more experienced treater. And I'll try to kind of differentiate that as we go through these bullet points. So hepatitis B co-infection. So all of the hepatitis C medicines have a black box warning about the risk of hepatitis B reactivation in the setting of Hep C treatment. So I'll say that again. All of the hepatitis C medications, not just Epclusa, has a black box warning about the risk of hepatitis B reactivation, which can be severe and sometimes result in liver failure or need for transplant. Now, that's rare, but that is what the warning suggests. And that can happen in the setting of hepatitis C treatment. So patients who have Hep B and Hep C co-infection, they need treatment for their hepatitis B first before you treat their hepatitis C. So we say that these individuals need to be referred to a specialist, but I will suggest that these are patients who also could be just treated by an experienced treater. So if you're an experienced treater, whatever that means you feel comfortable treating Hep C, or you've treated Hep B and C co-infection before, that can be done in a primary care setting or, by a non-specialist. But the point is that it just has to be done by somebody who feels comfortable treating hepatitis B and hepatitis C together. And it's very easy because really you just need to put them on like a tenofovir-based product, or put them on basically medication for their hepatitis B. And then once they're on medication for their hepatitis B, they can be treated for their hepatitis C. HIV, Hep C co-infection. This is another one, really. This is even easier to me than hepatitis B. It's just about comfort, because we know that patients for their HIV are treated pretty much the same when they're co-infected with Hep C versus if they're mono-infected with Hep C. So you don't have to do anything differently than what we're going to teach you about hepatitis C treatment in general. So you can feel comfortable treating patients who are co-infected with HIV and hepatitis C as long as you just feel comfortable doing that. If for some reason you don't feel comfortable, then we say, hey, refer them on to a specialist or an experienced treater. But to me, those who are infected with Hep C and HIV, they're easier to treat than those really who have Hep B and Hep C co-infection, because as the treater, you don't have to do anything else. I'm assuming these individuals probably will already be on HIV medications, and then you just treat the hepatitis C. Pediatrics, so again, those individuals will probably be referred to a specialist or experienced treater, because the only difference really in pediatric is that it's a different weight-based dosing. So again, it's not that they have to be referred on, it's just more to your comfort level. And it's just based on weight at that point in terms of how you treat those individuals. So for pregnant women, the label in terms of Clusa is still not approved for pregnant women. So right now, there are trials going on. There's data that's been out about safety in pregnant women, but it's not officially approved for treatment in pregnant women just yet. Then we've talked about decompensated cirrhotics. Those individuals, they need to be referred to not just a specialist, they need to refer really to a transplant center if they're decompensated. And then prior DAA use. So remember, all of these new class of medications for hepatitis C, which are all oral therapies, they're called DAAs, directly acting antivirals. So if someone has previously been on a directly acting antiviral as their only therapy, so they only received oral medication, those individuals cannot be retreated with Epclusa. So if they were only on an oral regimen, then you need to send those to a specialist or an experienced treater. And again, if you become more experienced at treating, then you can treat people who have received only directly acting antivirals. It's just, again, to your comfort level. So a lot of people just don't feel comfortable with it, but it's not that it's complicated or more dangerous. It's just, what do you feel comfortable with? And do you feel comfortable going to the next line agent after someone has failed Epclusa therapy? And if not, then it's perfectly fine. Refer that to someone who is either an experienced treater or to a specialist. And another caveat is medication consideration. So we'll talk about this a little bit more when we talk about the treatment in and of itself. But there are certain classes of medication that can be more challenging to treat when you're also giving Epclusa. And for example, amiodarone or the anti-epileptics like oxcarbazepine or carbamazepine or phenytoin. It's not really recommended that you use those together. Now, Epclusa has no medication that's a contraindication. So you can use these medications. It just becomes a little bit more complicated in how you use them together. We will talk you through that in the sessions that are upcoming. But I just want to let you know that if you are aware of some of those drug-drug interactions and you don't feel comfortable prescribing Epclusa or managing someone for their hepatitis C when they're on amiodarone or they're on anti-epileptics, or even if they're on statins, which we'll talk about has some drug-drug interactions, or if they're on acid-suppressing medicines like PPIs for their heartburn, et cetera. If you just don't feel comfortable with certain drug-drug interactions, that's fine. Then you can refer those on to a specialist or more experienced treater, or like we always suggest, you can bring it to the Project Echo and we can try to help guide you through that as well through this forum. Next slide. So, who is treatment experienced? This is important to recognize because there are people who are treatment experienced, but they're treatment experienced with interferon-based therapy, meaning that they had interferon with ribavirin, or maybe they had interferon with one of the more recent directly acting antivirals, but we don't use them anymore, like broseprevir, cimeprevir, telaprevir. Then those individuals, even though they are treatment experienced, they can be retreated with directly acting antivirals like Epclusa because they had a previous regimen that we know Epclusa is effective for. So the way you find that out is that a lot of patients may not remember what their previous treatments were, but if they tell you they took shots once a week, now, it has to be once a week, not just episodically, because often patients get confused. They think they were treated with shots and really they were just getting vaccinations. So you can clarify that for them by saying, hey, did you get treatment for your hepatitis C where you gave yourself a shot once a week? And if they gave themselves a shot once a week, then that is treatment experience that you can still treat with Epclusa. Next. But if they tell you they only received an oral regimen, then you cannot treat those individuals with Epclusa. So if they failed therapy with only Harvoni or Mavorite or Zepatier, again, the directly acting antivirals that did not require interferon to go with them, and they only received oral medications, then you cannot retreat with Epclusa and you need to refer those individuals on, or if you feel comfortable, you can go to the next line of therapy for those individuals. But we do not spend time during this Project Echo in discussing that category of patients. Any questions about this slide? All right, next slide. All right, any questions in general about prognostic scoring systems or who to refer or anything before we get to the steps of then when you actually prescribe the medicine, which um, Cindy will kind of cover in our next Project Echo for the new year.
I just had one question. If you have a hepatitis B patient and you start the Variad, how long should you wait before you're able to start the Epclusa?
Yeah, I feel like these medicines are so good that to me, as long as once they're on treatment, if they have very high viral load, I like them to be on treatment for at least like 2 to 4 weeks, before starting treatments. If they're one of those viral loads that's like in the millions, 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 and especially if the liver tests obviously are also abnormal, then I'll have them on treatment for at least 2 to 4 weeks. But everyone else, as long as they have started treatment with Hep B, I feel comfortable starting Hep C treatment with not much of a time break in between because the medicines are just so good for hepatitis B.
Dr. Lange, I have one question. If the patient has TB and they're being treated, do you wait until they've completed their TB treatment, or is it okay to go ahead and start the Hep C treatment?
I'm assuming you mean latent TB, so they're like the
Yes, ma'am.
long.
Yeah.
Yes. So then, yeah, no, that's a fine. You can go ahead and start treatment, yeah, because they're on latent TB treatment for so long. So that's not a problem. Now, okay, let me caveat there. Okay,
Okay.
it's not a problem with the TB treatment, but if they're, I mean, in terms of being on treatment, but there is a drug-drug interaction with rifampin, right? Because rifampin lowers the concentration of just about any medication, not just the Hep C medicines. So if they're on a rifampin-based regimen, then you may not be able to start treatment because it will lower the concentration of the Epclusa. So that's more related to the drug-drug interaction, not just that they're on, you know, treatment for the hepatitis, for the latent TB itself. Does that make
Okay.
sense?
Yes, ma'am.
Okay.
Thank you very much.
This is the hepatitis B treatments. Do the people are people actually cured, or is this a
No,
surprise?
so hepatitis B is not curable, not with medication, not that we think of like realistically. So
Right.
it's just suppressive therapy. And so
So,
what you'll have to do is you'll have to decide at the end of their Hep C treatment, do they need to continue on hepatitis B treatment? Now, there are guidelines that tell us when to start hepatitis B treatment. And so what I'm going to do is I'm going to actually, and Chrissy, remind me of this, when we do the special considerations population, or we have another time, I can spend a little time going through Hep B, but I think Cindy does in her some of her didactic too. Cindy, is that in part of yours as well?
It is.
Okay, yeah. So we'll spend a little time more on that next session, talking about in general hepatitis B treatment and management. And if it's not covered, I will also add to what are the indications for hepatitis B treatment because there are guidelines for when you start people on treatment. We don't treat everyone with hepatitis B for their hepatitis B because of the fact that it's not curable and it's not quite clear that treating just everyone results in improved outcomes. Now that is debatable and it's been a hot topic in the hepatology world. So people are moving towards this idea that we need to be treating more people than we do, and that the guidelines for treatment they think are not liberal enough. So we'll discuss that. But basically, if you're starting someone on treatment because they have Hep B, Hep C co-infection, because anyone with Hep B and C co-infection warrants Hep B treatment anyway from the beginning. But then obviously, if we're putting them on Hep B treatment because we want to treat their hepatitis C and we want to prevent a flare of the hepatitis B, then once they finish their hepatitis C treatment, you will have to then go back to guidelines in terms of how you decide if the person stays on hepatitis B treatment or do you take the hepatitis B treatment off. And you have to be careful because even taking hepatitis B treatment off in people who are mono-infected with hepatitis B sometimes can cause a flare of their hepatitis B.
Okay, thank you.
Mm-hmm.
Landry, one more question. If you have a patient that's a hepatitis B surface antibody negative, but hepatitis B core antibody positive, but they have not received their hepatitis B surface antibody negative, so they haven't had an immunity, and you want to start treatment, would you recommend starting the vaccinations first and then giving them a couple vaccinations for the hepatitis B? Or would you recommend doing lab work routinely when you start the Epclusa? How would you recommend dealing with
So I
that?
think this has shifted. This is our fifth year of the elimination initiative. And our initial algorithm, when we talk about that later, you will see that if they have what we call isolated Hep B core antibody positive, meaning that the surface antigen is negative, so they are not co-infected, but the surface antibody is also negative, meaning that we don't have evidence of an immune response. These are individuals who probably were exposed to Hep B, cleared it on their own. So those are the ones who can be more cured if they cleared the virus on their own, but they just don't have antibodies present. We initially said that you would want to check a Hep B DNA to look for occult infection and just make sure they're not co-infected. But occult infection is so rare. And what we really think is that these individuals have antibodies, and if they were exposed to hepatitis B, they would mount an antibody response. So the feeling has moved to treating these patients like you would just treat if they had Hep B antibody positive and don't really worry about the risk of reactivation because that's highly unlikely. So more and more now with those who are isolated hepatitis B core antibody positive, I really don't do anything differently. I just treat them like I would if they were immune, to hepatitis B. Then that brings up the next question. Well, do these individuals need vaccinations or not? I do go ahead and vaccinate these individuals, but you don't have to wait to vaccinate them to start treatment. And there are a group of hepatologists who feel like you don't even need to vaccinate them because they feel, like I mentioned, that if they were exposed to hepatitis B, they would mount an immune response.
Thank you, Dr. Landry.
Those are all good questions. Any other questions? All right, if no questions, then we'll move on to the case.